Warm welcome to all my students. Today we are going to have an interesting discussion on intravenous fluids. Intravenous fluid involves supplementation of a fluid for intravenous therapy through the veins to restore or maintain the normal fluid volume and electrolyte balance when the oral route is not possible. Why intravenous fluid therapy is required? Because it is an efficient and effective way of supplying fluids directly into the intravascular compartment in replacing the electrolyte losses and in administering the medications and blood products. To understand this, we must have some basic concepts known. This is the properties of a fluid movement from a compartment, one compartment to the other. So let us try to understand what is osmosis. Osmosis involves the spontaneous movement of water across a semi-permeable membrane from the region of a low solute concentration to the region of a high solute concentration to equalize the solute concentration on either side of the membrane. Then osmotic pressure. Osmotic pressure involves hydrostatic pressure necessary to counteract the process of osmosis. So what I understood? Osmosis involves spontaneous movement of water across a semi-permeable membrane from the region of a low solute concentration to the region of high solute concentration in order to equalize the solute concentration on either side. Hydrostatic pressure is necessary to counteract the process of osmosis. Then osmolarity. Osmolarity is osmolar concentration of a solution expressed as osmoles per kg of water. It is with regard to the weight per kg of water. Whereas osmolarity is osmolar concentration of a solution expressed as osmoles per liter in terms of volume per liter of water. About 80% of the total osmolarity of the interstitial fluid and plasma is due to sodium and chloride. 80% of the total osmolarity of the interstitial fluid and plasma is due to sodium and chloride ions. Half of the intracellular fluid total osmolarity is due to potassium ions, and the remainder is due to the intracellular substances. Fluid is distributed into two main compartments, intracellular compartment and extracellular compartment. Of the extracellular compartment, we are again interstitial compartment and the plasma compartment, intravascular, which is the plasma. So, the major ion in the extracellular space is a sodium ion. The intracellular space, it is a potassium ion. This we should remember. Osmotic gradient is the difference in the osmolarity of the two solutions on either side of the semi-permeable membrane. Again, to summarize, human body is composed of approximately 50 to 60% of water, out of which 2/3 of the total body water is present inside the cell. It is called intracellular fluid compartment. 1/3 is present in the outside portion of the cells. It is called extracellular compartment, is ECM. Extracellular fluid is further compartment is further divided into plasma, which comprises 1/4 of the extracellular fluid volume, and interstitial compartment, which comprises 3/4 of the extracellular fluid volume. Total body water is equal to intracellular fluid, which is 2/3, extracellular 1/3. Extracellular fluid is further plasma, which is 1/4, interstitial fluid compartment, it is 3/4 of the total volume. Volume occupied. Interstitial fluid is comprised of electrolytes, amino acids, glucose, hormones, and various other products of the metabolism. The cell membrane potential is essential for moving the substances back and forth between the cells and the blood vessels. Intracellular fluid and interstitial fluid compartments are separated by a relatively impermeable membrane. The impermeable membrane, which allows only water but no other substances to pass through the membrane spontaneously. Interstitial space and the plasma are separated by a capillary membrane, which is relatively permeable, allowing the molecules to pass easily across the membrane. Oncotic pressure. From the volume, the intravascular compartment, the protein, which albumin, which is a protein present in the vascular compartment, cannot cross the capillary membrane usually, and it is responsible for creating a oncotic pressure, because it is not easily crossing the capillary membrane. Exerts a pressure to keep the fluid within the blood vessel, protecting it from being drawn into the interstitial space. So, oncotic pressure, which is exerted by the albumin, is responsible for retaining the fluid in the vascular compartment. And is essential for maintaining a blood pressure. If at all, because of the disease condition, if it crosses, if it is leaking, then it leads to the edema of the interstitial edema, because of the collection of the fluid in the interstitial region. Anasarca if the extensive accumulation of the fluid in the extracellular compartment happens, it results in the anasarca. You have to remember the osmotic pressure exerted by the proteins such as albumin is called the oncotic pressure. Then you must know some terms when we talk about the fluid, about the tonicity. The tonicity refers to the measurement of an effective osmotic gradient between the two fluids separated by the semi-permeable membrane. It's the osmotic pressure gradient. It's the effective osmotic gradient which is essential to maintain the movement on either side of the semi-permeable membrane. It is influenced by the solute concentration. Which cannot cross the membrane. The most common way to categorize the intravenous fluid is based upon their tonicity. They are classified into isotonic, hypotonic, and hypertonic. Isotonic intravenous solutions have the same concentration of the solutes as of plasma, blood plasma. Hypertonic solutions are those solutions having the solute concentration less than the plasma. Hypertonic solutions have the greater concentration of solutes than the plasma. Normal plasma solute concentration is 285 to 295 milliosmoles per liter. 280 to 295 milliosmoles per liter. So when the osmolarity is less than the plasma osmolar concentration, the fluids are termed hypotonic, and the solute concentration is equal to the blood plasma concentration, they are called hypotonic, and the solute concentration is greater than that of the plasma, they are called hypertonic fluids. Based on the source, fluids are divided into three. Hypertonic solution. Hypertonic solution has a greater or either higher concentration of solute. And when the cell is immersed in this hypertonic solution, water tends to flow out of the cells to balance the concentration of the solutes, causing the cell to shrink in size. Isotonic fluids. Isotonic meaning they have the same concentration of the solute as in plasma, solutes as blood plasma. When infused, isotonic solutions expands both the intracellular fluid and extracellular fluid spaces equally. Such fluids do not alter the osmolarity of the vascular compartment. Technically, electrolyte solutions are considered isotonic if the total electrolyte content is approximately 310 milliequivalents per liter. Isotonic intravenous fluids have the total osmolarity close to that of the extracellular fluid, They do not cause red blood cells to shrink or swell. The fluids are further classified into crystalloids and colloids. Crystalloids are the IV fluids of solution containing small molecules that flow easily across the semi-permeable membrane. Depend upon their relative tonicity in relation to plasma, they are of three types: isotonic, hypotonic, and hypertonic. So let us try to understand some of the features of some of the isotonic fluids. Example: 0.9% sodium chloride, which is called as normal saline solution. Normal saline solution, or NSS, is a crystalloid isotonic intravenous fluid that contains water and sodium and chloride ions. Sodium is 150, sodium present at 154 milliequivalents per liter, and chloride content is 150 milliequivalents per liter. Total osmolality is 308 milliosmoles per liter. It does not provide any calories because there is no glucose or any substrate which can provide energy. These solutions are called normal saline because the percentage of sodium chloride dissolved in the solution is similar to the usual concentration of the sodium and chloride in the intravascular space. Normal saline is isotonic solution of choice for expanding the extracellular fluid volume because it does not enter the intracellular fluid. The fluid is administered to correct extracellular fluid volume deficit. It remains within the extracellular fluid. It is basically for correction of the extracellular fluid volume. And it is compatible with the blood products. It is a fluid of choice for the replacement of the fluid loss due to burn injuries and polytrauma. However, it is not the fluid of choice for heart failure, pulmonary edema, or renal impairment. So also the conditions are associated sodium retention, which may risk fluid volume overload. Why? In case of heart failure, pulmonary edema, renal impairment, or conditions associated with sodium, because of the sodium, there will be retention of the volume of the water along with the sodium, resulting in the volume overload. Hence, it is not the fluid of choice in these conditions. Even though it is normal saline, it is called the normal saline. The chloride content is high, and large volume of normal saline supplementation will lead to hyperchloremic metabolic acidosis. So, large volume of the normal saline infusion is not acceptable. Next solution isotonic dextrose in 5%, dextrose 5% in water. It is called D5W. It is a crystallized isotonic fluid with osmolality of 252 milliosmoles per liter. Initially, it is isotonic solution which can provide water and dextrose, but when dextrose is metabolized, the solution becomes hypotonic, which will expand the extracellular fluid and intracellular fluids. A liter of D5W provides fewer than 200 kilocalories and contains 50 grams of, because it contains 50 grams of glucose. It should be avoided in case of a head injury associated with the raised intracranial pressure, and it can lead to cerebral edema. Next isotonic fluid is lactated ringer. Lactated ringer solution, also known as Ringer's lactate or Hartmann solution, is a crystallized isotonic IV fluid designed to be the near physiological solution containing the electrolytes sodium 130 milligrams per liter, chloride 109 milligrams per liter, potassium 4 milligrams per liter, and calcium 3 milligrams per liter. It contains bicarbonate precursor as a lactate to prevent acidosis. It will not provide any calories or magnesium, but provides limited supplementation of potassium. This is the most physiologically adaptable fluid because its electrolyte content is most closely related to the composition of the body's blood, serum, and plasma. Uses Ringer lactate is used to correct dehydration, sodium depletion, replacement of the fluid lost through the gastrointestinal tract. It is also used to treat the fluid loss following the burns, fistula trainees. It is often administered to the patients with the metabolic acidosis. Lactate gets metabolized in the liver and gets converted into bicarbonate. But if the patient or the person is suffering from the liver disease or lactic acidosis, because the liver cannot metabolize the lactate to bicarbonate, it should not be considered as a fluid of choice. It should be used with caution in patients with heart failure and renal failure. Ringer solution is another isotonic solution. It has a content similar to that of the Ringer lactate solution, but does not contain lactate. It contains acetate. So it can be used when Ringer's lactate is contraindicated, like a liver disease. Let us learn something about the hypotonic intravenous fluids. Hypotonic intravenous fluids have the osmolality lower than that of the plasma. They cause a fluid shift from extracellular fluid in fluid to intracellular fluid to achieve homeostasis, thereby resulting the swelling of the cells, and they will swell, they will get swollen to the extent that they may even rupture. IV solutions are considered hypotonic if the total electrolyte content is less than 250 milliequivalents per liter. Hypertonic intravenous fluids are usually used to provide free water for the excretion of a body waste and treat cellular dehydration and replace the clear fluid. What are the uses? They are for excretion of body waste, to correct the cellular dehydration and replace the clear fluid. Examples include half normal saline or 0.45% sodium chloride. Half normal saline or 0.45% sodium chloride is a hypertonic intravenous solution used for replacing the water in patients who have hypovolemia with hypernatremia. Excess use may lead to hyponatremia due to dilution of sodium, dilutional hyponatremia it's called, especially in patients who are prone to water retention. The osmolality of normal saline is 150 milliosmoles per liter that contain 77 milliequivalents of sodium and 77 milliequivalents of chloride, total 154 milliosmoles per liter. Hypotonic sodium solutions are used to treat hypernatremia and other hyperosmolar conditions. The other hypotonic solution include 0.33% sodium chloride. 0.33% sodium chloride solution is used to allow kidneys to retain needed amount of water and is typically administered with the dextrose to increase the tonicity. It is administered with because it's hypotonic and it's administered water in order to increase the tonicity. It should be used with caution in patients with heart failure and renal insufficiency. The hypotonic solution that is used in case of pediatric patient is 0.225% sodium chloride solution, which is used as a maintenance fluid for the pediatric patients. It is one of the most hypotonic intravenous fluids that's available, having only 77 milliosmoles per liter of the solution. It is used with the dextrose to increase the tonicity. Next hypotonic solution includes 2.5% dextrose. Another hypotonic solution commonly used at 2.5% dextrose in water, Solution is used to treat dehydration and decreased levels of sodium and potassium. Should not be administered with blood product as it can cause hemolysis of the red blood cells. Hypertonic. Now let us learn something about hypertonic intravenous fluids. Hypertonic intravenous fluids have a solute concentration greater than that of the plasma, more than 375 milliequivalents per liter. They cause fluids to move out of the cells into the extracellular fluid, shrinkage of the cells. In order to normalize the concentration of the particles between the two compartments, intracellular and extracellular. So they cause the cell to shrink and may disrupt their function. They are often known as a volume expander as they draw water out of the intracellular space, increasing the extracellular fluid volume. Hypertonic sodium chloride solutions contain higher concentration of sodium and chloride than the normally present solids in the plasma. Infusion of hypertonic sodium chloride solution shifts the fluid from the intracellular space to the intracellular to the interstitial and intravascular. Hypertonic sodium chloride solutions are available in two strength, 3% and 5%. 3% sodium chloride contains 1030 milliosmoles per liter of the solutes, which include 513 milliequivalents of sodium and 513 milliequivalents of chloride. 5% sodium chloride, on the other hand, contain 1710 milliosmoles per liter of the solutes. 855 milliequivalents per liter of sodium and equal 850 milliequivalents per liter of chloride. Hypertonic sodium chloride solutions are used in the acute treatment of sodium deficiency, that is severe hyponatremia, correction of the severe hyponatremia, and should be used only in a critical situations to treat the hyponatremia. They need to be infused very slowly to avoid the risk of overload and pulmonary edema. If it is administered in large quantities rapidly, they may cause extracellular volume excess and precipitate circulatory overload and dehydration. They should be administered cautiously when the serum osmolality has decreased to a critically low levels. Some patients may need diuretic therapy to assist in fluid excretion, used in patients with the cerebral edema. They are mainly used in patients with cerebral edema, raising tension. Hypertonic dextrose solutions. The isotonic solution that contain 5% dextrose, that is D5 normal saline solution or D5 lactated Ringer's solutions, are slightly hypertonic since they exceed the total osmolality of the extracellular fluids. However, dextrose is quickly metabolized and only isotonic solution remains. Effect on the intracellular fluid is temporary. Hypertonic dextrose solutions are used to provide calories. With the dextrose means they will provide calories to the patients for a short term. Higher concentration of dextrose, 50% dextrose, or the strong hypertonic solution, and must be administered into the central veins so that they can be diluted by rapid blood flow. Dextrose 10%. D10W. Dextrose transfer in water is an hypertonic IV solution used in the treatment of ketosis of starvation and provides the calories. Usually it will provide, the fluid will provide 380 kilocalories per liter. Also free water and no electrolytes supplemented. Should be administered using through the central line. Should be infused using the same line. Should not be infused in the same line as blood product, as it can cause red blood cell hemolysis. 20% dextrose in water is hypertonic intravenous solution, an osmotic diuretic that causes fluid shifts between the various compartments to promote diuresis. 50% dextrose in water is a hypertonic solution used commonly to treat severe hypoglycemia. So the fluids are hypotonic, isotonic, hypotonic, and hypertonic. Isotonic fluids include normal 0.9% normal saline, lactated ringer solution, and 5% dextrose in water. Hypotonic fluids include 0.45% or half normal saline, 0.33% normal saline, 0.2% normal saline, and 2.5% dextrose. Hypertonic 3% normal saline, 5% normal saline, 3% normal saline, or 5% normal saline with dextrose. More than 5% dextrose, okay. 10% dextrose, 20% or 50% dextrose are hypertonic. Uses isotonic solutions are the normal saline used in the resuscitation, shock, fluid challenge, metabolic alkalosis, the compatible with the blood and blood products, used to treat hyponatremia and diabetic ketoacidosis. Should be used with caution in patients with heart failure, pulmonary edema, and hypernatremia. Can lead to fluid overload. Ringer dextrose used as a supplementing solution for dehydration, burns, gastrointestinal fluid loss, acute blood loss, hypovolemia. As it contains potassium, may lead to hyperkalemia in renal failure patients. Patients with liver disease cannot metabolize lactate, so ringer lactate should be avoided. D5 as a 5% dextrose for the fluid and fluid loss, dehydration. Case of hypernatremia, solution becomes hypotonic when dextrose gets metabolized. It is not a fluid of choice for resuscitation. Used cautiously in patients with the renal failure. Then comes the other category of the fluids, colloids. Colloids contain large molecules that do not pass through the semi-permeable membrane. Colloids are the iode fluids and contain the solutes of high molecular weight. Technically, they are the hypertonic solutions, which when you exert osmotic pull of fluid from the interstitial and extracellular space. Useful for expanding the intravascular volume and raising the blood pressure. Colloids are indicated for patients with the malnourished states, and patients who cannot tolerate the large infusion of the fluids, crystalloids. Again, example, human albumin. Human albumin is a solution derived from the plasma available in 2%, 5% and 25%. 5% albumin is in the plasma and is commonly utilized chloride solution used to increase the circulatory volume and restore the protein level in conditions such as burns, pancreatitis, plasma loss through the trauma. 25% albumin is used together with the sodium chloride to restrict the polymorph load. Considered it should be used cautiously. Use the same protocol and nursing precautions as blood transfusion and administering the albumin. Albumin is contraindicated in patients with the severe anemia, heart failure, known sensitivity to albumin. Additionally, angiotensin converting enzyme inhibitors, AC inhibitors, should be withdrawn for at least 24 hours before administration of albumin because of the risk of atypical reactions such as hypotension and flushing. Next colloids includes dextrons. Dextrons are available as a low molecular weight dextrons and high molecular weight dextrons. They are the polysaccharides. Dextrons interfere with the blood cross matching, so draw the patient's blood before administering the dextron if cross matching is anticipated. Low molecular weight dextrons have molecular weight of 40,000 dextron 40, used to improve the microcirculation in patients with the poor peripheral circulation. They contain no electrolytes and used to treat the shock related to vascular volume loss. Example, burns, trauma and surgery. On certain surgical procedure, low molecular weight are used to prevent dextrons are used to prevent venous thromboembolisms. They are contraindicated in patients with the thrombocytopenia, hypofibrinogenemia, and hypersensitivity to dextron. High molecular weight, dextron 70 or 75. Higher molecular weight contains polysaccharides molecules with average molecular weight of 70,000 or 75,000. Patients with the hypovolemia and hypotension. Contraindicated patients with the hemorrhagic shock. Amplified starch. These solutions are derived from the starch and are used to treat intravascular fluid, used to increase the intravascular fluid volume, but can interfere with the normal coagulation. Heta starch and olivine. Gelatin or other colloids. Gelatins have a lower molecular weight than the dextron and therefore remain in circulation for a short period of time. Then next colloids include plasma protein fraction. Plasma protein fractions include the solution that is prepared from the plasma, and like albumin is heated before infusion. It is recommended that they should be infused slowly to increase the circulatory volume. So the fluid management is an important topic, and because you have to handle the fluid supplementation in fluid deranged and electrolyte imbalanced or unstable, hemodynamically unstable patients in a trauma, ICU, surgical wards, and also medical and various clinical conditions. The knowledge of the fluid supplementation should be known, and the fluid should be supplemented judiciously, because fluid should be used as a drug. Various type of fluids and their indications should be known to a treating physician, and fluids should be supplemented judiciously. Thank you. You are welcome for clearing your doubts. If you are not having any doubts, let us end the session. Thank you.